series, a virtual meeting that speaks to bring you peace and comfort at a time of great fear, anxiety, and grief. This is part of our effort to bring relief to all people. And I'm honored to be the moderator of this panel. As most of you will know, my name is Koyin Ajayi. So with us this evening are, a number of great Nigerians, and our two key resource persons are men of great outstanding achievement. The first is Professor Shola Olopade, MD, MPH, FCCP. I don't know what that means. Maybe he'll speak a bit about that. He's a professor of medicine and director of international programs at the University of Chicago. He graduated in medicine from the College of Medicine, University of Ibadan in 1980. His specialist training in pulmonary critical care and sleep medicine was at the world famous Mayo Clinic, Rochester, Minnesota, United States of America. He also underwent ethics fellowship training at the University of Chicago, and he's got great experience, and he is a great clinician and clinical scholar who's conducted research in areas of his expertise in the United States, in Asia, in Nigeria, and indeed many parts of the world for a number of years now. He's highly skilled pulmonologist with expertise and special clinical interest in asthma, chronic obstructive lung diseases, bronchitis, eosinophilic lung diseases. In short, he's a COVID-19 expert. He's widely traveled and steeped in Nigerian healthcare system from a public health to preventive medicine perspective. Shola, as is well known, brings his baritone to play in the most important subspecialty in the worst of worst cases of coronavirus. He spends his spare time farming when able to do so in Okoigbo, Ondo State, if he is not with his amiable wife herself, a leading world expert in breast cancer. Welcome, Professor Olopade. Second on our panel this evening is Dr. Yemi Oshindero. He obtained a first-class honors degree in chemical engineering and then proceeded to Bath University to obtain his PhD in the same subject. He's an investment banker who co-founded Virgin Nigeria Airways in 2005. He ran it as Chief Operating Officer, having started his career in England with Goldman Sachs and thereafter with Standard Chartered Private Equity, where he invested close to $1 billion across Africa. He's sat on several boards, including that of Union Bank, GZI, and Abuja Disco, which provides us electricity. He currently runs his own private equity firm called Ukuru Capital, which invests in different sectors in West Africa. Yemi is an avid runner, focusing on long-distance marathon running. He's participated in no less than 10 marathons all over the world. And in using this, he raises money for charitable causes. But more important, what Yemi brings to the table tonight is the fact that he is one of those that built within 21 days a world-class field hospital in Etiosa at the landmark Center Water Corporation Drive in Oniru. He serves as treasurer of the steering committee of COVID-19 medical response team of a group called YPO, Young Professionals Organization. These two men will be supported in audience interaction by three other doctors. Dr. Oyebode, Deji Oyebode, who was with us last week, a forensic psychiatrist, as he calls himself. Dr. Yabo Kudaya, who was our moderator last week, the CEO of Lifeline Children's Hospitals, herself a consultant pediatrician, and Dr. Jimi Coker, who is one of the most critical persons in critical medicine in Nigeria. He's CEO of the Lagoon Hospitals, and he is himself a surgeon. So they will provide us also deep insights into physical and mental health issues. This evening, our panel will speak to new methods of dealing with COVID-19. I hope drawing from the experience of Shola in the United States, especially the battlefield of Chicago. He'll shed light on facts and myths about COVID-19, about Black people, about our hot climate, which his president talks about, and pre-existing conditions that we have. From Yemi, we hope to learn about his clinical experience, about spaces, public health spaces in the country. I hope we'll learn more about stigma, about isolation, and good service. So without much ado, let me hand us over to Yemi with his opening statement. Yemi.
Thank you very much, Reverend Cohen, and thank you for having me here today. So I wanted to talk a little about what it was that we did at YPO. YPO is a Young Presidents Organization. It's an international organization of CEOs of different companies who believe that the world needs better leaders and come together to exchange ideas and learning. It's a constant journey of learning. And as this COVID crisis started unfolding very early on, we felt that there was a need for us to do something. It wasn't enough to just complain about the situation that we find ourselves in Nigeria, but rather to act. And that's what we sought out to do. We felt that we could catalyze some of the early things that needed to be done to make this happen. And then we could reach out to the wider stakeholders, the wider communities in the private sector to raise funding for a world-class hospital. Having seen many of the public hospitals that we have in Lagos, I was especially concerned, just given the fact that they're already full today before COVID comes in. And if we saw anything like what we were seeing in everywhere else in the world, in Wuhan, in Italy, in Spain, in England, in America, we were grossly unable to defend ourselves in that scenario. And so we thought we had to act. We reached out to our networks and everybody that we knew. We started placing orders for equipment, which take weeks to come in. And I mean, as part of the membership of YPO, we have some people who are in the medical field, and a number of the doctors that were involved there, Lagoon Hospital, Hygeia, Pathcare, Sygen, there are quite a few medical people, 9 doctors in YPO. We were able to draw on that expertise and start to order the equipment that we need, start to pull together the healthcare professionals that we needed, and start to pull together a hospital that would be operational. We handed this over on Monday to the governor of Lagos State. Lagos State will be responsible for the operations of the hospital. It's ultimately a 90-bed hospital, of which we have 10 ICU beds, so able to provide clinical care to a world-class standards. And I remember when the governor came, he was particularly impressed at the fact that we could treat the most severe cases of COVID that you would find in this place. And there are not many other places that have that capability in Lagos. So with the ICU unit, with the respirators and ventilators that we have in place, we would be able to respond to this disease as it deserves. So I'll pause there and hand over to Reverend Cohen.
Thank you, Yemi. Professor Olopade, can we hear from you before we then get into the meat of the day?
Yeah, thanks, Emmanuel, for asking me to be part of this panel, and I'm very impressed and delighted that we've been able to put in place a world-class hospital to take care of probably the most challenging cases we'll ever see. But these truly challenging times globally, as we all work towards surviving the COVID-19 pandemic. And I think it's clear that this is one of the most dangerous infections we've ever seen, and probably even worse than the 1918 flu pandemic that also killed millions of people. And the special danger in this virus, lies in its highly infectious nature, even before affected patients start to show any signs of infection. While we've learned a lot in the United States in managing patients with this infection, there's a lot we still need to learn, to effectively manage the infection. And I just want to say it up front. I mean, as of today, there are no known and confirmed effective medication to treat the infection, although they're encouraging ongoing studies looking for a cure, including the development of an effective vaccine, which I think is probably what's going to be necessary to protect all of us. Until we cross that bridge, my recommendation to everyone is to do our best not to get this infection, because the outcome is very, very unpredictable. And in this light, if I don't get the opportunity to say it again, we need to really follow the social distancing recommendation. We need to wear masks when we're out of the house to protect ourselves from people, and also to protect people from us, because this is a droplet infection. You sneeze, you cough, you can infect people very easily. And then those that have access to water, I think hand washing is probably the most effective treatment that we have now, because for a virus that's as virulent, the soap actually breaks down the lipid membrane and kills it instantly, as long as we don't inhale or put our hands on our faces and get infected. So for now, that's what I'm going to suggest we do before we get into the meat of the discussion. But thanks for asking me to be part of this panel.
Thank you, Prof. And again, ladies and gentlemen, welcome to the Emmanuel Chapel COVID-19 webinar. Michael, can you please show me on the screen? I'd like to show something before I ask the first question. I'm seeing Professor Olopade. Michael, can you show me? We're still seeing Professor Olopade.
You can see my new COVID COVID look.
So everybody can see this.
Okay.
So this was given to me by one of my colleagues, Tosin Akinbade. So this is chloroquine by Mayan Baker, and this is chloroquine called Maxiquine with Piriton, both given to me by my colleague Tosin Akinbade the day my office shut down, which was before Lagos itself announced the lockdown. And she gave them to me just in case, because at that time, Trump has started touting, as indeed a number of people online, that chloroquine and hydroxychloroquine were effective in dealing with coronavirus. And a number of us, because this is readily available, actually do go and buy this. And because a number of us, show symptoms that are similar to that of, coronavirus, cold, cough, body aches and pains, fatigue, some of us would jump on this. So I'd like to ask, Shola, is this the right thing to do? Should we buy this drug and keep it at home and self-medicate?
I think the first thing I'd like to say is please don't listen to our president at all on any of these issues. And then the second point is the efficacy of chloroquine is actually not proven. You know, in the setting of an epidemic, it's not unlikely that when we don't have known and effective medicines that we try different medications, but they're usually under controlled settings where, you know, there has to be at least some reason why we think such medications might be effective. And what would typically happen is you take one group of patients, you give them the chloroquine, and then you give another like sugar pill, and then see the outcome, because if the chloroquine is effective, then the chloroquine group should survive, whereas the sugar pill people would die. And that's exactly what has been done in the United States, where if you look at, that's how we do clinical trials to decide whether medications actually work or not. If you look at a study that was done in the VA system in the United States, they did exactly what I just described to you by recruiting about 370 veterans with COVID infection. And they divided them into 3 groups. 97 of them, they gave them hydroxychloroquine. The second group, they gave them hydroxychloroquine and an antibiotic, which is called azithromycin or Z-Pak. And then another 158, they didn't give them anything. Okay, and this is what the outcome looked like. This is our clinical trials on how we decide what medications to adopt. 27% of the veterans who were in the hydroxychloroquine group died, okay? 22% in the hydrochloroquine and azithromycin died. The people in group C who were not given any of this medication, only 11.4% of them died, okay? And the rate of needing to be on the ventilator for the 3 groups was similar. So based on some of this studies, this is how we make our judgments on what works or what doesn't work. You can see that those that were given hydrochloroquine because of some of the propensity to cause cardiac adverse effects, they did worse than people who are just left alone and didn't take chloroquine. So from my own advice is, there's absolutely no reason to start dosing chloroquine, because there's absolutely no evidence that it has any efficacy or should be adopted for the treatment of COVID. And when we look at studies like this is how we make decisions. If people who didn't get chloroquine survived more than people who got it, so why would anybody why should we recommend that anybody should take chloroquine? So please, just use it for malaria. Don't dose on it for COVID. It won't help you.
All right, thank you very much, Prof. I'm going to move quickly on, taking on self-medication. At the beginning of this week, the public space was awash about sad news of mysterious death of over 150 people in the ancient city of Kano. Some theorize that many of the dead are people with pre-existing conditions. Some theorize that some of them self-medicated. We're told that, you know, there's a lot of diabetes, high blood pressure, asthma, you know, hypertension in a number of, you know, the people that died. And generally, as you know, being an expert in healthcare here, that these are some of the preconditions that a lot of us have. Indeed, when Lagos State did a study of, you know, public transport drivers, they found that a high number of them, you know, have high blood pressure or no. Now, in the latest edition of the Journal of the American Medical Association, they say these pre-existing conditions affect the sickest COVID-19 patients. What would you say about that study, number one? What would you say, in addition to what you said about self-medication and these pre-existing conditions and COVID-19 infection or contagion in this part?
Regarding the first part with respect to Kano, I mean, people can die from anything, but it doesn't seem to be enough information. But if being in crowded settings is what happened there, and they don't have access to care, and COVID found a way to get there, yeah, it will kill a lot of people before you know what's happening. With respect to the predisposition to adverse outcome, yes, I think people with underlying comorbidity, whether it's hypertension, diabetes, asthma, it doesn't actually increase the likelihood of getting infected. But having those comorbidities, especially if they're not well controlled, could be an important mediator of outcome if one happens to come down with the infection. But this is not something that access to good quality care and people who know what they're doing can overcome. If you look at specifically some of these comorbid conditions that you listed, people who have obesity, from the pulmonary perspective, they tend to have, collapse of their lungs, even when they're just moving around, because of the obesity and the restrictive nature of it. And if you look at the biggest challenge that people who have COVID infection have, with respect to infection of the lung or the flooding of the lungs, you need all the lung capacity that you need. So anything that leaves you compromised from being obese puts you at greater risk of an adverse outcome. If you look at hypertension on its own, people who have poorly controlled hypertension at increased risk of having strokes and heart attacks like that. For unclear reasons, people who also have COVID infection, we're seeing a lot of thrombotic episodes, meaning that they form clots, that can form in the lungs. It can lead to strokes. It can lead to heart attacks. So when you superimpose having underlying poorly controlled hypertension on how COVID works, you can see how the adverse outcome may happen. Similarly, it's the same thing with diabetes, because a lot of these patients, if they don't come in early enough and have been having fevers and have been dehydrated, most people with COVID, when they come into the hospital late, we are finding now that they actually present with elements of kidney failure. So diabetics are already prone to have underlying kidney failure. Yes, it's possible that some of these comorbidities may increase the outcome, but in very good hands, it shouldn't be a death sentence. So access to good quality care and recognition of this comorbidity we've seen a lot of people with those comorbidities survive very well. But if you're looking at people who are poor, who haven't had access to good care and good control, yeah, it's gonna be an increase. They'll have a high likelihood of increased mortality. But I don't think anybody with hypertension or asthma that's well controlled should, be too panicky that it's just gonna knock them out.
Thank you very much. I think that is a bit comforting because there's been a lot of myth out there. My nephew, for instance, has asthma, and So he's under total lockdown. He's not seeing a soul. So I guess, for us, it's nice to know that we can observing good social distancing rules as long as we manage our pre-existing conditions well, carrying on with life. Mike, can you show me a pulse oximeter? Can you show the public a pulse oximeter? Because I'd like to ask a question about that, because that's something else that I think is important. So while this comes on, that's a pulse oximeter, and I'm sure many of us would have seen this when we go to clinics or hospitals. This little thing we put on our finger and they use to measure oxygen. Now, Professor Oyebode, there's this Dr. Leviathan, who in New York Times of April 20, in an article called "The Infection That Silently Killing Coronavirus Patients," said that COVID pneumonia initially causes a form of oxygen deprivation called silent hypoxia. And it says this silent hypoxia is hard to detect, very dangerous, but at the same time, it's very easy to find out. And that with an oximeter, which we can get, and I'm sure you can get it from Jumia, it costs only 5,000-6,000 naira. That if we get this and we measure oxygen, we get to know whether oxygen is high or low. And if we see it's falling low, we can just quickly go to a hospital. And if we're infected, we'll be treated very quickly and we therefore don't need a ventilator. So my question, Professor Oyebode, is one, should we all get oximeters? Number two, does it help in avoiding the use of ventilators? And number three, must we all get on ventilators if we are ill? Because that's part of the problem some of us have, that ventilators themselves cause a problem.
I think it's important to understand what, God is great. I mean, the way the body was built, it's like a very, very efficient computer system with good feedback mechanisms. If you look at people who have infection with COVID and the timeline, within the first 5 days, you start having symptoms and, people have gone through, it can be mild, but people who really have a tough time have these very high fevers. And some develop pneumonia and some don't. The pulmonary component of it could be from the virus itself causing pneumonia, or it could be from what we call cytokine storm, because this virus replicates so quickly, and when some of the millions of copies are released and the body is trying to fight against the virus, it creates like a war zone and causes collateral damage, which causes flooding of the lung along with the infection. And the challenge with, depending solely on a pulse oximeter is the more compromised your lung is, the more the system will tell you that there's a problem, because then you'll develop shortness of breath. It's very difficult to accept that you will have low oxygen without your body making you breathe hard. You'll experience some breathing difficulty. The challenge with the exposure to, with the course of COVID is you have fever. By the time you start having shortness of breath, there can be a very dramatic and rapid decline and needing to be on the ventilator. So by the time you have access to be checking your pulse oximeter at home, if you're not close to a healthcare system, you might be dead before you actually show up. So that's what we've seen, and that's why having access to, even when they say manage it at home and start taking your temperature, we don't know now who's going to have that accelerated course and that's exactly what happened in New York. And if you have flooding of the lungs and you don't have any oxygen, the blood that's perfusing the brain with no oxygen, people are just coming in like zombies. You'll be out of it. Okay, so maybe that's what they're calling silent hypoxia, but that's usually a process where the shortness of breath will be the warning to you that this is getting out of hand. It's going into your lungs. If it's just the fever, you can ride out the fever and be checking the fever every day. But the moment you start having shortness of breath, you better be very, very close to somebody who can get you to one of the centers that I've just described. Otherwise, you'll be dead before you get there. You know, so yeah, pulse oximeter can give you the recording, but that's usually at the late stage because most of us, when we're doing okay, your oxygen, even when you're having the fever, high respiratory fever, your pulse oximeter will be normal. But you'll have shortness of breath before you have that decline. So being close to somebody who can get you to help is what you need to make sure you have if you come down with this infection. But the way they're doing it in Nigeria is once you have it, they don't even allow you to stay at home. They just grab you. And I think this is the point to actually say it, that we should make sure that having COVID infection is not a stigma, because it is not. Because people are hiding because they don't want people to know that they've had it. It's just, you know, accident just because we've walked around, you know? So it's important for people to know it's not a stigma. You know, we should let people know so we can do the contact tracing and not put people more at risk. I like the idea of getting people to a center where they can monitor them. And that's probably why some of the mortality data in Nigeria is probably not that bad, because people are not just out there and just precipitously crashing before they can get access to healthcare.
Okay. Thank you very much. Michael, please, can you give me that public record of 1918, 1919 virus flu? Can you show that, Michael? While Michael is doing that, we're going to switch after this. I'm just going to ask Professor Oyebode and Yemi one question, and then we'll switch to questions from the audience. I'm sure if you're on Facebook, you know where to pose your questions, and if you're on the webinar or Zoom, you know where to pose your questions. Please, make your questions as short as possible. Put your name, and I'll get to see them. We'll try and take as many of the questions as possible. We want to end this, in good time to make sure that our Muslim brethren can go away to break their, pray and break their fast. So I'm just going to ask one more question of both Yemi and Shola, and then we'll move to your questions. So please begin to ask your questions. One thing that is clear from what Professor Oyebode has said now is that we should not please buy oximeters. We should not go on Jimi to get them. We should not try and self-treat. And I think the warning that NCDC has given about being careful as to where we go for treatment is very important, because we should not think that there is a stigma to this ailment. So let me switch baritone voices, and I'm going to ask Yemi first and then ask Prof to also jump in. And you've both spoken about ventilators. In another report yesterday on Sky News, it is said that CPAP, which is a little machine, a little box, which people with apnea or sleep disorder use, is being used in place of ventilators. So, we know that ventilators are quite expensive. So first question, should those of us that have CPAP machines at home continue to use this if we think we have coronavirus? That's the first thing. And I'd like you to please address that. Yemi, I'd like you to let us know. Thank you very much for what you've done. And we thank your donors also. But there are a number of people that are opting to go to private hospitals, like our deceased chief of staff. And I think this is because of the failure of successive governments to address our health needs. It's clearly obvious. Also clearly obvious that our various successive governments have not addressed social infrastructure and how to reach the poorest of the poor, other than during elections, when they're going out to get votes, they reach every house. But now they're not able to do so. So, Yemi, can you tell us what else you think needs to be done? What else can the private sector do to help in bringing health to the people beyond what you have done? What do you think will be done with the equipment and the facility that you have built once this has disappeared? And so I'm asking a few questions together. So just to remind you, Yemi, I'd like to know what else we can do to help government in helping ourselves.
Yeah.
I've asked, Professor Oyebode and yourself whether we should be using CPAP in place of ventilators, because ventilators are very expensive. And my last question, I hope Toyosi Alabi, my colleague, is listening. Toyosi Alabi is my partner, and she stands or sits in the sun between 10 a.m. and 12 noon every day in order to get a good degree of vitamin D from the sun, because she believes that vitamin D deficiency is a contributory factor in a disproportionate amount of the death of African Americans in the US and the UK. So, Prof, I'd like you to talk about that. Should we be sitting out in the sun, not staying in air-conditioned homes? Prof, that's one question. Vitamin D, which TLC gets from the sun, sitting outside, not sitting in air conditioners. Is that something we should be, going for? Yemi, what else can we do to help? And what should we be doing about COVID-19? And on top of that, is that statistics. Mike, can you show it again? It shows that 2.5% of people in the South died of a pandemic in 1918. 2.3% in the North died. If we have the same statistics today, it means 5 million Nigerians will die. So what is it that we can do to make sure that this doesn't repeat itself? And after this, you've answered this million of questions, move to the public. I hope I haven't confused you. Yes, okay. Gentlemen. Yemi, maybe you should start.
Right. Yeah, happy to. Look, I think the point about what else. First of all, the state of the current healthcare in Nigeria is dire. And I think anyone who's worked in a hospital can attest to that. Yes, you have, and here I'm talking about the public sector. Yes, there are very good private hospitals in Nigeria. They can solve most of the things that you will have. Medical tourism is huge. Nigerians spend over $1 billion a year on their healthcare, to the US, to the UK, to India, to all of Europe, to Singapore, to you name it. Nigerians are there spending money on healthcare. So that gives you an idea of the sort of lag that we have. We have not invested in our healthcare collectively as a people. And so why are people opting for the private hospitals? It's precisely because of that. The public hospitals are not geared up to deal with this issue. And I think I said earlier, they're already full today, before COVID, full of people with, all sorts of underlying conditions, like Professor Oyebode was talking about earlier, and, people with all sorts of diseases already. So there's a huge, huge intervention needed there. And the truth is, this will end, the clouds here will go, the storm will pass. When it ends, we really need to ask ourselves what we're doing to prevent the next pandemic, the next, we've had Lassa fever, we've had Ebola, there's Warburg, there's all sorts of viruses out there. What is the next one, and how are we going to be prepared for it? And then you ask the question, what else can we do? So we all as Nigerians, I think we all as humans have to act, because we are at war. And truly, this is a remarkable historic time. I think for the first time in probably all of humanity, 7 billion people are fighting the same enemy. I'm sure we can win the war, but it needs everyone to pitch in. So everybody has to do whatever they can. If you can, please donate to the war effort. And this war effort will be fought on many, many different fronts. One front of the war in Africa is ensuring the lockdown is a success. And that means that people who live day to day get food so they can stay off the streets. There's a Nigerian saying, all die not die. Whether you die of hunger, whether you die of corona, you're dead. And hunger can kill people. So by all means, those who can, donate to feed the underprivileged, because every little helps. The second is getting testing in place so we can identify people who have the disease and track them. If possible, we can use technology to do so. South Korea has done this very, very well. They use an app, it tracks you as you move. They know when you're getting close to too many people. They know places that have the spread of the virus. They can rush there and contain it. So it's phenomenal. And this is stuff that we can do with the telecoms data we have today. So this is stuff we can do tomorrow. The third is isolation and treatment. You know, there are a few other isolation centers that have been built. For the more moderate and the more severe cases, as they start getting critical, you need world-class treatment centers, similar to the one we've just handed to Lagos State. So, you know, I think all the fronts of the war are essential to win the war. We have to fight all of them. We cannot do one and hope to win the other. You know, and I think in this regard, Emmanuel Chapel has been a truly wonderful example, feeding 60,000 people, donating respirators to Lagos State, and also donating to the YPO center that we opened. By the way, the center has got 11 patients now already, since it opened 3 days ago by the governor. But we're still taking donations for working capital and additional PPE to protect the health workers that we have we've identified and put there. So I would ask people who are so moved to please donate. Please let us know. We'll let you know how if you're interested, and would love to get your support. So I think that answered the how can people help question. Sorry.
Thank you, Yemi. But you didn't tell us you were a masquerade, because you see you're behind a lot of masks. So we put one of them on. You want to put one of them on? Yeah, Prof, can you please quickly respond? And so I have a lot of questions for you all.
Yeah. Starting with vitamin D. I mean, it's wonderful to go out during the day to get some fresh air and vitamin D. But vitamin D has been blamed for a long time, you know, as the cause of many ailments that plague Black people. They think it's responsible for asthma, hypertension. We've tried it for everything. And I'm not surprised that people are making associations that don't necessarily prove causality. And the challenge is that we just don't drink enough milk. You know, most Africans don't drink enough milk, because when you drink milk, where most of us are lactose intolerant, you know, and people don't want to be messing up the air. So just like I said with the chloroquine, people are really trying to do quick research, you know, searching databases and trying to figure out whether vitamin D has a role. It's not too different from a study that was done in the United States, where they were looking at mortality related to COVID based on whether you had access to broadband internet or not. When you look at it, people who didn't have access to broadband internet, they died more than people who did. So is this the broadband access that, you know, is therapeutic for COVID? Probably not. It's all about poverty, because people who have access to broadband are probably richer and can afford better quality of life, unlike people who have. So again, no study, people are rushing to bring out a lot of association and publishing them now. But vitamin D is really not a treatment for COVID at this point in time, but it's okay to go out fresh, get some fresh air and some sun. It's recommended, but not for COVID.
All right. Thank you, gentlemen.
Regarding CPAP,
Yes.
you know, in terms of managing pulmonary complications of COVID infection, you know, what we really try to do, at least at the University of Chicago, is try not to get people to be intubated and mechanically ventilated. We've done a lot of things in terms of using high flow oxygen, but being very, very careful because this virus is aerosolized. So making sure that in doing high flow oxygen to try and get the blood oxygenated, you don't get people infected. The other thing that we've done is to actually do proning. You know, when you're lying on your back, there's a tendency for all of the fluid and infection to go to the base of the lung. And what we've been doing as a strategy and when you have fluid, it means the lung sacs are flooded and you cannot really exchange you can't extract oxygen from the air that you breathe. So periodically turning people upside down to recruit new alveoli in gas exchange is one, but that's something that needs experience and expertise. And also at the University of Chicago, I sent a clip of that to Enio earlier. We actually also use helmet ventilation, which is just like a little, you know, you just put like a helmet around people's head without, it's sealed. And it's a way to ventilate without really violating the upper airway. And similarly, CPAP, by virtue of the way it works, it just opens up the airway to recruit more alveoli to participate in gas exchange. So all of those interventions to avoid the need to be on mechanical ventilator is what we recommend. But if that's not successful and people need to be on the ventilator, so be it. Because at the University of Chicago, we've been able to deploy this very effectively. The number of people that we are needing to ventilate are very few. And as of now, the average stay in the hospital for people who have COVID and come to the University of Chicago is about 5.8 days. And you have to put it in the context of where we are. We're on the south side of Chicago. We are 90%, 60% of the patients that we see are Black people. So it's got nothing to do with being Black. If you have access to good health care, even though you may have some of these comorbidities, you can survive this.
Okay, thank you very much, Prof. So I have a number of questions here already. The first is from Tola Adigbai, who is a director with Midway Assurance. She says statistically, over 11 million people die in Nigeria every year, 11 million. 4.7 as of 2017 statistics related to pneumonia and nutritional diseases. 4.7, pneumonia, which is your field, Dr. Olopade. 1.5 from malaria. And she says, why are we spreading dread on coronavirus when we have not paid the same attention to why our people die so cheaply? She says dread doesn't seem to help, and we are not promoting preventive measures and early treatment. What say you, Prof? And also, sorry, Dr. Coker, can you also comment on that after Prof?
Yeah, you know, when we don't just label diseases as pandemics, you know, when you have the label of pandemic, it means these are equal opportunity infections that will kill everybody, okay? And this is even more challenging because people are already spreading the disease before they know. So the opportunity of just for it to be cascading, all you need to do is just look at something that started in Wuhan. We're up to almost 3 million people have died. Look at the data that was showed earlier about the H1N1 flu from 1918. These things kills and there is no treatment for it. Okay, if we had a treatment for it, we wouldn't be paying as much attention. Malaria and all of those other mortality, you know, what I'm hoping will happen after all of this COVID pandemic stuff is over is we'll go back, because it's very easy to actually throw money in the middle of a pandemic when people are scared, they want to protect themselves, they want to protect other people. That's when we know we have poor people among us. What would be very, very nice is to go back and use this episode to ensure that people have access to water, they have access to good sanitation, we have power, we have good healthcare system. That would be the best thing that could happen, because all of this money that we've thrown out now, at the end of it, there will be no viable infrastructure in place, you know, to continue to make sure that people have access to good healthcare so that people don't die from malaria, people don't die from nutrition, people don't die from all of those other diseases that are important. But a pandemic and a highly infectious disease like COVID needs the kind of attention that we're giving it. It doesn't mean that we're not, you know, worried about people who die from malaria and nutritional deficiencies because they don't have access or because of the social determinants of health that makes them more vulnerable to dying from those preventable causes.
Okay, Dr. Coker, do you want to comment on this?
Thank you very much. I think Prof. Olopade had said one or two things. The most important is the fact that those other conditions that were outlined, we have cures for them, but we don't have at the moment for COVID-19. Malaria doesn't cause a crash in world oil result, you know, with imminent recession. So we need to put things into context. Also, a lot actually has been done for malaria because there's a rollback malaria program. Per head of population, we have fewer cases of malaria now. And if one interrogates the data, you find that this is also related to some extent to poverty and malnutrition. And yes, those things need to be treated. And I also would like to emphasize that most of the work being done on COVID-19 also relates to prevention. Hence the emphasis on hand washing, hence the emphasis on physical distancing, hence the emphasis on the need to, if you know, there is a suspicion, to self-isolate so one doesn't then infect other people. Thank you.
Okay, my next question, or the next question is from Lizzie. And this is for Dr. Oyebode from England. Deji, Lizzie says, how do you protect yourself, your mental health? How do you protect your mental health to avoid anxiety and stress with all the COVID-19 news confronting us each day? Dr. Oyebode.
I think my practical suggestion is, if you can, distance yourself from the news, because you're not going to hear anything positive. Mm-hmm. I'll give you my practical example. The only thing I listen to now during the day is a briefing from number 10 Downing Street. Because the scientists are there, the medics are there, they're being challenged. We want to know what is going on. Apart from that, journalists are just going to report what they want to report, and each journalist wants to report more than the other one. So which newscaster is reporting it first? So there's a competition. If you can, you don't need to listen to the news. Okay. I don't care, but you have control. You can switch off your television or radio. The only good news we want to hear now is when the vaccine is going to be available. And we heard yesterday that Oxford University has started testing for vaccine yesterday.
Thank you very much. Your last point answers Andreas's question as to when vaccine will be available. But I'm sure you can't answer when it will be available in Nigeria, in Africa. But as you said, it will be available. So Andreas, your question has been answered. And in relation to Tola's point, I hope some of us are close to politicians and people in government to speak to them about the answers both Professor Olopade and Dr. Coker gave as to the need for governments to do more in relation to what they're doing. Leads me to the fourth question from Chukwu Emeka. He says, at what point should one with signs of COVID-19 visit the hospital? At what point should one with signs of COVID visit the hospital?
I think, you know, the way they're doing it in Nigeria, just like they did for the Ebola, is just fantastic. It's better for people to actually come and get you to instead of just showing up unannounced and exposing other people to this infection. My understanding is that people have a number they can call if they think they have COVID, and that people will come to you and take you to a controlled setting where you can be managed. Because I don't think we have massive testing in Nigeria that allows people who have tested positive and can self-isolate at home to take care of themselves. That's what we're doing in the US, but I think in Nigeria, because there are not too many places people can go, I like the approach, the current approach of the government to just send people and bring people to where they can get good care and prevent them from spreading it further.
Okay, thank you very much. So this leads me to the next question from, I believe, from Danjuma. I don't know which Danjuma is this one. Probably Ocholi Danjuma. He says, how do we know which hospital facility has the capability of treating the disease? And I think Dr. Coker and Dr. Kudaya should speak to this, because this is about Nigeria. Which hospital facility, you know, should we go to? And please, we know we have the Etiosa facility. There's a facility in Yaba, in Lagos. We know what's happening in Lagos. There was a photograph of what Kebbi State is doing. Basically one yellow room with double beds of a secondary school without any equipment. So, you know, they want, you know, we'd like to know, you know, Danjuma says, what kind of hospital should we go to? Can you answer this, Dr. Kudaya, Dr. Coker?
I don't know whether Yaba wants to start first or I go first.
Please go first.
Right. Okay, there you are. Do you want to go first?
No, please go first, Dr. Coker.
All right. So, like Professor Olopade mentioned, currently treatment for COVID-19 is centralized. So, if one suspects that one has COVID-19, there is a number to call. Calling that number, a team from Lagos State and CDC will come to do the testing. The person will also be assessed. The assessment is often done by teleconsultation. And once the person is assessed and found to have symptoms highly suggestive of COVID-19, then another team will come to evacuate the person to one of the treatment centers. Now, which treatment center should one go? This is actually centralized. There is a call center that is manned by doctors. These call centers will then, they have the available bed spaces at the different facilities and the different levels of care. And the patient will then be triaged to the appropriate facility, either in Yaba. Yaba is also being expanded now, Onikon, or of course the Landmark Center. There's also a 200-bed facility in Bagada. So currently there is sufficient capacity. One hopes that the numbers don't increase. There is a project that is also going on currently, and I think it will be rolled out either this weekend or early next week, of another call center that will help Lagosians who have health problems but don't think they have COVID-19. Because what we currently have is that there is fear of going to hospitals. There are also some hospitals that have actually completely shut their services. Some are working with reduced capacity, and some are working full-time. So this call center, which should be rolled out early next week, will help direct people to the appropriate healthcare facilities. But for people who feel they have COVID-19, then the best thing is to call the toll-free numbers for support, and that will come from Lagos State and NCDC. Thank you.
Thank you very much. I think maybe just points to add to that is the fact that Lagos State is training and retraining a lot of healthcare staff on how to manage COVID-19, which is very important. Not just any hospital can manage it, particularly if you haven't had the requisite training in infection prevention and control, breaking of transmission. I think Lagos State is also training a lot of people on contact tracing. So they have a team that is going, trying to do a lot of contact tracing that they send out. So I think when you consider those points, unless you have had the training before now, it is difficult for a hospital to manage. If people come to your facility, there should be a screening center before they actually go into the actual facility. And if you do suspect that they could have symptoms of COVID, because you would administer a questionnaire, and a lot of people now, as Dr. Coker said, are moving on to telemedicine, where you can see the patient, or some other forms of consultation, WhatsApp consultations. Then you can actually help prune these patients down and advise them where to go and make the phone calls for them.
Okay, thank you very much. And I guess so what you're both telling us is that if you feel you have COVID-19, we should call the call center and not go to any private hospital. So moving quickly on, there are a number of questions here, and I like to take questions that are personal first to people's health. There's a question here from Yemi. She says, he says, given all that has been said, what is the best way to protect a diabetic person? And I think it's very, very important. What is the best way to protect a diabetic person? Any of the doctors to please give this.
I think the diabetic person should just make sure that their diabetes is very well controlled. That's what you should do. And you shouldn't be stressed any more than that. People who have good control with hemoglobin A1C that's less than 7% have the same outcome. So just like we said earlier, if you have hypertension, asthma, and all of those things, if your underlying comorbidities are well controlled, the outcome, if you get infected, would be better than if they were not. So I don't think you need to be overtly anxious about that if you've been doing what you're supposed to do in ensuring that your diabetes is well controlled.
Okay, another question that is personal, and this person is anonymous. This person has hypertension. It says, kindly enlighten me regarding the use of vitamin D tablet 1 a day. I don't want to take chances knowing this is not prescribed by my doctor. Hypertensive patient, vitamin D. In answering that, Dr. Lokade, Tola Adebayi, in her usual manner, has pushed back and said that there is research from the North, NHS, yes, NHS East London, 14th of April, which advises the use of vitamin D. So that's from Tola. So she pushed back on vitamin D. And someone else also pushed back on vitamin D. The person is also anonymous. It says, why are preventive measures, more important, adequate nutrition supply needed nutrients with supplements of vitamin D3 and vitamin C. What do you say? So questions, what most important, and please you should answer this, if nothing else, this person with hypertension and vitamin D? What do you say? And then you can, in that, answer Tola and the other anonymous person on vitamin D3 and vitamin C.
You know, I think, you know, in America, where I live and practice, I mean, people, it's a big industry. All this vitamin and nutritional, it's a big industry. And as I tried to explain earlier, how we make decisions about whether even Tylenol or paracetamol is better than just taking sugar pill. That is a process where we do studies and evaluate, just like I told you, about what was done with the VA group regarding the need for chloroquine. To my knowledge, I don't know that there have been any studies that have actually randomized people into whether you are going to be treated with vitamin D or no vitamin D, or whether it's just an addition to ongoing therapies towards treating this. Because to be able to convincingly say that an intervention is helpful, the two groups have to be comparable, and you have to be able to isolate the impact of vitamin D. To my knowledge, no study has been done to show the way we usually do clinical trials, that if you add vitamin D to this potpourri of the same potpourri of medication, that adding vitamin D has a superior outcome. You know, associations don't always prove causality. That's why I gave the analogy about broadband earlier. You can't just infer that vitamin D, maybe they did that and I'm unaware of that, but today I'm not aware of any study that's demonstrated convincingly the way we do clinical trials that vitamin D is an independent mediator of outcome.
Thank you. So Tola, and I'm sure Tola is going to come back. I guess what Prof is saying is that there are a number of studies, but they're not deep enough to pass clinical tests.
I can give you another very good example. You know, Gilead Sciences, they have this antiviral remdesivir, you know, that they developed for Ebola at that time. Everybody was happy that there was something that we could use for Ebola. But when they did the study and tried remdesivir against another, mortality in the remdesivir arm was higher than the other control group. In our experience at the University of Chicago, most of the patients that have received remdesivir, within a short period of time, they get better and they go home. But we can't, based on that experience alone, say that now everybody should be getting it, even though it sounds that it's a good therapy. Until you look at the data, you compare with the other alternative, and you see whether it's better. You really can't define therapy based on observations like that.
Okay, thank you very much, because I still have a number of questions to go through. So Toyosi Alabi and Tola, I'm sure you had enough of vitamin D. So now I'm going to put that at the very end about lockdown, because there's a question on that, and I'd like you to answer that at the very end in relation to what you call an equal opportunity disease. So Shola will come back to that at the very end. But let me just take some other, questions here. Justice Ni Ademola says, do we need a different policy for Nigeria and Africa, distinct from Western countries, to fight COVID? Well, I'll take that later because that's about lockdown. Sorry. So Justice, we'll take that with lockdown. Kunle Adebayo says, well, that's about lockdown too. So Kunle Adebayo will take that later. Tunde Hassan Odukale says, is there a correlation between the recent briefing at the White House regarding weather and humidity with our experience of low contraction numbers, extreme morbidity and mortality in Nigeria? So, doctors?
I think if that were true, because, you know, usually some of these viruses, like the flu, they happen during the cold winter months, okay? And people think that the viability of the virus is protracted during those periods, and that during the hot weather, they would die quicker. But then if that were true, all we need to do is just look at Nigeria and other warm climates where the temperature, the humidity hasn't stopped the spread of this virus. So I wouldn't be listening to, you know, President Trump's assertion that the weather, when it warms up, all this will wash away, because we can just look at what's happening all over the world. The weather difference is not stopping the spread of this pandemic. So we need to be working on protecting ourselves from not coming down with the infection.
Okay, thank you. I'm going to go to a question by Segun Adeniji, Victor Segun Adeniji. And it's a question for the doctors. It says in Nigeria, the present practice is prioritizing testing for individuals presenting multiple or advanced symptoms of COVID-19, possibly due to the shortage of test kits. And he says that he understands that this presents a danger, because the longer you wait, the more likely it is that you get a false negative report, because the virus may have traveled from the nose, which is where they take this test, to the lungs. What do you say, doctors, to this?
Yeah, I actually disagree with that, because if one looks at the efforts of the Lagos State government and the NCDC in the last 2 weeks, it's been quite commendable. There had been extensive contact tracing. In Lagos, more than 2 million. And they have the people at risk that have been identified with the process of the contact tracing have been tested, and those positive isolated. So I don't really, that is not my experience, that we are only looking after people with advanced disease. They tend to be the sickest. They tend to be the ones that would seek help in the first instance. But all the others who are either pre-symptomatic or asymptomatic with the disease that are detected during the contact tracing and testing process have been isolated. What we have had, because of the stigmatization that was alluded to earlier, people have been hiding or often also not telling the truth about their travel history or contact, which has made part of the job difficult. But I think insofar as the contact tracing and testing has gone, it could be a lot better, but within the resources that they have, I think they've done a decent job.
Okay, thank you very much. All right, Olumide Ogundaunsi, in short, asks that what other therapeutic options are available beyond behavioral changes while we await a vaccine? What therapeutic options are available? Any of you doctors, any one of you should please answer.
From my own experience, the approach to care now is multi-layered to try and ensure that people who have high fevers don't get so dehydrated and develop kidney impairment, that they can have adequate hydration, they can eat, and then you can intervene with respect to when they need oxygen supplementation, if they develop what appears to be a bacterial infection superimposed on the viral infection, which is very common. You treat that. It's mostly just supportive And people are also, in the setting of this pandemic, trying different medications based on our understanding of the biology. So, all of those things are being done to try different combination of medications while waiting for the vaccine. Fortunately, many people have mild disease and don't go through that kind of ICU care, but there are many people who have actually also required ICU care that have survived COVID. So I think access to good quality and supportive care and being able to intervene when other things happen, which is what we do in critical care and pulmonary medicine, is still saving a lot of lives. But the one that's going to have the most impact is the vaccine, so that the whole world can be vaccinated and we can develop immunity, hopefully, towards this infection.
Thank you very much. There's a question from very Reverend Dr. Ralph Idialu from Shagamu. But I think that has been answered, because he says there's a lot of scare about death in Africa of COVID-19. But I think Dr. Oyebode has said, well, look, stop watching TV all the time and try and listen only to scientists. So the next question is from Port Harcourt, from Aliruchi Kokiga. She says there's apprehension by people generally about taking vaccinations to prevent COVID-19, probably because of negative information by social media. How can these concerns be addressed by the medical profession as the world awaits an effective vaccination? And I think this is very important, doctors, because as those of you familiar with public health in Nigeria, at a point in time, there were parts of the country that opposed vaccination for polio because it was said to be, anti-X or Y. So Ali Ruchi from Port Harcourt says, there's still this apprehension. What can we do to allay our fears? And I think that's an important question.
So, I would like to suggest that, people who are, anxious about getting correct information should actually pay regular visits to the WHO site because they're technocrats. They're working with most of the countries of the world. Forget about what the United States political issue with WHO is, but the WHO is a very reliable and trusted place to get information on the status of the pandemic. And yes, it is true that there are some vaccine candidates that have been tested in little pockets, but there is really nothing available yet to show that one is going to be effective. If and when one that is going to be effective is identified, they will go through the same rigor of the clinical trial, just like I described earlier, before people will get to get them. It doesn't preclude people who want to really participate and volunteer to participate in research early to become engaged. But my assumption is when it gets to Nigeria, it probably would be when it's already been demonstrated and we know how it works.
Okay, thank you very much. As we have just 12 minutes to round up, I'm going to press on very quickly. There's a question from Adisa, and I would like to ask the two Nigerian doctors residents in Lagos to answer this. It says, SPO2, I don't know what that means, SPO2, I'm sure you would know. It says that COVID-19 patients at home are using SPO2 or SPO2 because SPO2 goes down gradually without the patient knowing if SPO2 goes down below, say, 80%. And so it says that, what should you do about SPO2? Should you shout if there's damage or what? SPO2, I don't know what that means. You would know. So, doctors?
Yeah,
Dr.
well,
Coker,
it's actually, that was the first thing we addressed. The pulse oximeter you spoke about. Yeah, SpO2 is just the oxygen saturation, which is what the pulse oximeter measures. And I think Professor Olopade had addressed that to say that by the time the SpO2 goes down, then there is already significant damage to the lungs, and one shouldn't really wait for the SpO2 to go down before one seeks medical advice.
Okay.
Am I right, Professor Olopade?
Exactly.
Yes.
All right.
Thank you.
Okay. So, Adisa, there you go. And to all of us, please, let's seek attention. Akinjide Akinola asked you pointedly, Dr. Coker, that you've spoken highly about Lagos State facilities. Yemi Oshidera has spoken highly about what they've done. Says, how about other places? Ekiti, he says, Kogi State, what's happening there? I mentioned Kebbi State. What's happening? We'd like to know.
Thank you. For Ekiti State, they opened the 120 bedded isolation center in Ado Ekiti, I think, last week. And they only still have 4 cases. So they have this is the advantage of the lockdown. What the lockdown does is to allow health systems to develop so that the spike in the number of cases and the rate of infection is reduced, and then the health system can develop to match whatever is coming after. So Ekiti, for example, they still only have 4 cases, but they have a 120-bed isolation center. And they also have, surrounding states that have done quite a lot of work. As you know, there is the facility in Osun State, I think is the Redeemers University there. They have a fantastic laboratory, and they have been able to provide a resource for that part of the country. I'm actually not aware that Kogi State has any case of COVID-19 yet, according to the NCDC site. But again, I'm sure that there will be things put in place to develop an isolation center in one of the main hospitals there. So a lot of other things are happening in other parts of the country, but might I remind everybody that Lagos is the epicenter, and there are, I think, more than, almost 60% of the cases currently are in Lagos State, hence the concern about Lagos and FCT. And appearing rapidly on the radar now, of course, is Kano.
Thank you. Well, I think I should mention that the COVID initiative, led by Aliko Dangote, Herbert Wigwe, Central Bank, Femi Chodola, and a few others, Mike Adenuga, are also building field hospitals all over the country. They built one in the stadium in Abuja. There's one coming up in Kano. There's expanding facilities in Lagos, and they're going to reach all the regions. So we will all, by the grace of God, have enough facilities. And we'll come back to the point you raised about the efficacy of lockdown. Before I get onto that, Engineer Yemi Adefule asked that, what are we doing about herbal remedies that have proven effective in combating COVID-19? Herbal remedies.
I have no knowledge of those, so.
Well, okay, no, we're not asking you, Professor Olopade, because in America you won't have. We're talking to Dr. Coker and Dr. Kudai. Herbal remedies.
Me neither. I am not aware of any. I know that quite a lot of things have been proposed, like ginger, honey, but really, apart from that, I'm not aware of any herbal remedies.
Okay, Dr. Kudai?
Same here.
Okay.
We hear a lot, take this, take that, take honey, take ginger, but we're not aware that any of those work.
Okay, so science doesn't yet, show this. Okay, thank you. So related to that is a question from Dele, who says that, does gargling with warm water and salt help to prevent COVID-19? Warm water and salt. Gargling. Doctors? Any doctors?
Good oral hygiene is always good, but to our knowledge, I don't think gargling or anything will dislodge COVID-19 if it's already there, but having good dental hygiene in general is good.
Okay, thank you very much. Benga Shonesi likes to know again about chloroquine. He says he knows someone who was treated with a combo of zinc, hydroxychloroquine, and antibiotics, and was pronounced negative after some doses. And so he's confused now as to, what to do.
In medicine, we call those anecdotes, because there's no way of proving that it's the chloroquine or the zinc that cured the patient. The patient's immune system, without anything, would have just led to the same outcome. So we call those anecdotes, but they don't prove causality or dictate what effective therapy should be.
Okay, I'm going to ask one question and then we'll come to lockdown and this equal opportunities disease. And this is from Aki, and he's worried about testing and says that it takes 3 days to get your result. And says, what happens within those 3 days? Isn't there a risk of contracting the virus? Isn't there a risk of contaminating other people within the 3 days? So what's the answer, doctors?
I think anybody that's deemed necessary to be tested should actually self-isolate, so that during the 3-day period of no matter how long it takes to get the result, you're not infecting other people. That's just the thing to do. You just have to isolate yourself from other people. You don't want to get the result in 3 days that it's positive, but during that time, you've been to church, you've been to the market, you've been with your family. So the advice is, if they've deemed it necessary to draw blood from you, you self-isolate until you get the results of the blood test.
Okay, thank you. So let's just come back to this big question and then we end the session. And it's about lockdown. I'd like, everybody to comment on it, including Yemi. There's this big debate as to whether we should end the lockdown. And the number of these is what a number of about 6 questions have asked. The ANA think tank, COVID think tank, issued a statement yesterday and said government should end compulsory lockdown and move to what it calls intelligent lockdown. The South African government issued today a statement that it is ending its own compulsory lockdown on May 1 and would phase in work in 5 stages. And so there's this big debate as to whether this lockdown is doing us more harm than good. Dr. Coker said, lockdown is good because it's allowing us to build capacity. The people who say, look, this lockdown is killing the economy, is creating hunger, may lead to social unrest. Nigerian Labour Congress says you've got to stop it. So what is it that you have to say? Can we get to hear from each of you on lockdown? To be or not to be?
Being that you've mentioned my name in association with it, can I make a clarification that I think what Lagos State was doing earlier was the more intelligent one, which was ensuring physical distancing, but people were still able to go along with their livelihoods, and then stopping, large congregations, because we know that in some parts of the country, particularly religious congregations, have been a source of spread of COVID-19. So I think a total lockdown, I completely disagree with. The whole principle is to physically distance as much as possible, and for the people with suspected diseases to self-isolate, or the ones that are coming in to be quarantined. So I think we need to be a bit more intelligent about what we do, and not just a blunderbuss approach of saying we lock everything and everybody down. That will not work with us. So that's my view anyway.
Yeah.
Thank you.
No, I think if I can speak, I think part of a big part of it for us in Africa and Nigeria in particular is the question of whether we can afford a lockdown. I mean, the lockdown has given us very valuable time to put capacity in place, to put testing in place, to put treatment capacity in place, and so on. But we cannot afford it. And if you think of the majority of Nigeria, certainly the cities, I think the rural areas may be slightly different, but in the cities, there is no social distancing. You can't social distance in most of Lagos. That's the reality. You know, maybe where, you know, parts where some of us live, you can, but if you are all packed in a face me, I face you, you cannot social distance. So our reality and the reality of most of Africa with this thing is going to be until there's a vaccine or there's herd immunity, whatever it takes to achieve that, we are going to have, you know, a continued rise of this disease, and we have to manage it, but we cannot shut the economy down because the cost of feeding, you know, the sheer numbers of people that would have to be fed, people who live hand to mouth, is unaffordable. So by all means, those who can afford it must keep themselves apart. Those who are high risk must keep themselves apart and protect themselves. But the majority, the vast majority of Nigeria cannot. That's the reality.
Thank you.
You know, it's a very scary proposition. You know, I've been locked down in my house now for about 5 weeks. We're using telehealth where, you know, just get up and walk in the evenings because we live in a comfortable place. But if you live in a face me, I face you, it's challenging. Unfortunately, from the public health perspective, a disease that's spread by, you know, by droplets, you know, has, you know, those places could serve as petri dishes for the spread of this infection, especially when people, you are typically spreading the infection even before they know they have it. You know, the anxiety, I understand the economic challenges. I understand the logistical challenges of getting people to lock down when people don't depend on the government to feed them. People work several jobs to feed their family. If we had a good and efficient system, like the politicians do during elections, they know how to get food to everybody. If it's possible to provide what people need so that they don't have to come out, that would be the ideal solution, because the anxiety that I have is that the data that Enio was shared earlier on the mortality related to the 1918 pandemic is what we might see in Nigeria if we're not able to contain it, because now we're beginning to get community spread. It's not just people coming from America or from the UK. It's already in the community.
It's
and
exactly
in those crowded places is when it's going to be there. You go to the barber, you go to the market, you know, those are the people that are going to make, and as long as we don't have herd immunity yet, all of us are going to be vulnerable. I don't have an easy solution, but if there is a way to ensure that people who need access to food can be reached so that they don't keep moving around and spreading stuff, we're all in for a very rough ride. That's a sad reality.
Okay. All right. Thank you very much. I'm afraid we have to draw the curtain. Dr. Kudai would take your answer next time. I'd like us to end here, especially because of our Muslim brothers and sisters, who I thank, and in the words, message from the governor of Nasarawa State, may the Almighty to whom you look make your fast acceptable and sincere. He make your standing up in prayer one of those who pray obediently, and may he awaken you from the sleep of the heedless and forgive your sins. To all of us, thank you very much for joining this webinar. I hope a number of questions that were important to us personally were well answered. I hope a number of myths have been dispelled. I hope that facts that are important to us have been brought forward. So we'll meet again next week, because we'll bring you another episode next week. We wish you all a very good weekend. Wish you all good health, and pray that as we continue to look to the Almighty for help in this time of trouble, we all keep healthy, obey social distancing rules, and continue to act responsibly. God bless us all. Good evening.
All right. Thanks for having me, Emmanuel. Bye-bye.
Bye-bye. Thank you.
Thank you.
Thank you. Bye-bye.
Bye.